Well, welcome everyone. I'm Dr. Carmen Pugliafito, host today on Retina Synthesis, and we have a distinguished guest, Ferhina Ali, who is Assistant Professor of Ophthalmology at New York Medical College. Welcome to Retina Synthesis, Ferhina.
Hi, Carmen. Thank you so much for having me.
You gave a very interesting talk at the ASRS annual meeting about Aflibercept monthly injections in diabetic macular edema, real-world experience. Can you tell us about the study and its design?
For sure. So thank you for the kind words. Our study looked at the impact of the initial monthly doses of patients receiving Aflibercept injections with a new diagnosis of diabetic macular edema in routine clinical practice. So we captured this information through the Vestrum database. As you know, it was founded in 2014. It's an electronic health records data analytics provider in the retina space. It was initially founded actually by retina specialists, but most importantly, it allows us to mine our medical records to capture trends and associations at a very large scale that historically we had not been able to do prior to databases like this and the Irish Registry, for example. And so that is generally the thought process behind the study and kind of the tools that we had available to us. But I think more importantly, we've known for some time through real-world studies that our patients receiving anti-VEGF are undertreated, and especially those with diabetic macular edema. And so we've seen in the past associations between the degree of visual improvement and the number of injections that patients receive, and not surprisingly, well validated now through large-scale real-world data that there is an association between the number of injections that we received and how much visual and anatomic gains that patients can have. So this was a study in collaboration with Regeneron and Rishi Singh of the Cleveland Clinic, and we looked at factors associated with the initial monthly dosing and the impact on visual and anatomic outcomes at 12 months. So these were newly diagnosed patients, 2015 to 2021, 25,000 eyes captured, and primarily looking at mean change in visual acuity, central subfield thickness, and then baseline factors associated with vision gains at 1 year, and also associated with receiving a higher number of injections. So that is the broad overview of the study.
Well, 25,000 eyes, that's amazing.
Yeah, these databases are very powerful. And so we're able to understand more nuance than in smaller retrospective studies, for example. What we did with our study design is we broke the patients up of the 25,000 into 3 groups. So group 1 were those that had received 1 to 2 injections, group 2, 3 injections, and group 3, at least 4, so 4 or greater, during the 16-week period following their initial first injection with a 2-week grace period. So kind of looking at that early, what sometimes is described as a loading period, particularly with respect to clinical trial design. And so what we saw was that in terms of the degree of retinopathy, so for the patients with PDR, we saw a decreasing proportion receiving more injections across the groups. And for severe and moderate NPDR, an increasing proportion. So in other words, more patients receiving more injections with that slightly lesser degree of retinopathy. And we can imagine a number of factors might be associated with this, specifically with respect to undertreatment for patients with PDR. In terms of those patients in group 1, those are our patients that were receiving just 1 to 2 injections. We saw some concerning things, which is that they had a longer time from diagnosis to treatment. They had fewer visits, more breaks in their treatment, and more losses to follow up compared to those receiving more injections. We also saw in terms of vision slightly decreased across the groups, and central subfield thickness increased across those groups. Now, in terms of looking at the associations when controlling for other factors of receiving fewer injections, we saw female gender as an important role, as well as age less than 65. Now, for those receiving a higher number of injections, associations with that were worse vision, as well as severe NPDR, central subfield thickness of greater than 300, and also the presence of fluid. In total, when we saw that with increasing injections, there were better vision and anatomic gains, both during that loading period, but also at the end of the study period, which was a 1-year study, and increasing trends for gaining 5, 10, 15 letters with more injections. And I think a really important finding in my mind is that we saw that eyes that had received at least 4 injections, so most paralleling clinical trial design, had a 49% higher chance of gaining 15 letters, not 15 years, 15 letters at year 1, which is very powerful. And we also saw that after that initial dosing period of the 16 weeks, that each injection thereafter was associated with an 8% higher likelihood of gaining vision. So in my opinion, a lot of this work really kind of validates what we might think in clinical practice, that, okay, if we treat more, patients do better, but it's important to be able to validate that at a larger level with data. But also, I think if we think about our treatment course more mirroring clinical trial designs, patients will do better. And most importantly, now we have more treatment options available, and we've ironed out a variety of operational issues with delivering anti-VEGF treatments over the course of several years in our clinics. And we're at this sweet spot where there's potential new medications on the horizon, but we also have the opportunity to understand the true potential of medications that we have and what gains specifically we may be leaving on the table with under treatment.
The Diabetic Retinopathy Network model really recommends about 7 injections a year. Do you have a sense of what percentage of patients had that number of injections?
Yeah, so that's a great question. I had a feeling you might ask that. I don't have that aggregate data for the 1 year, but as I was reviewing it, I was wondering the same thing. My suspicion is that it would be similar to what we've seen in the IRIS database, which is not 7 and often more closer to 4 to 6, which is, a finding we see over and over in terms of citing the undertreatment that we observe in the real world with diabetic macular edema patients. In the IRIS registry analyses, we do know that the neovascular AMD patients do a little bit better in terms of number of injections, but I believe the number for DME patients in IRIS is 4 to 6 in that year 1. I'll have to look back at our data to remind myself what we saw as average treatment number for the 1 year. We were primarily focusing on our analyses that we reported, looking at the initial monthly dosing period. But I can let you know what that number is. I'll check back with our group.
What can you speculate on the cause of the infrequent injections?
Yeah, I think we've long thought about what this may be related to, and a variety of things can be at play. So first of all, our diabetic macular edema patients tend to be younger. They're often working age, and that can limit their ability to come in very regularly for injections every month, or even anywhere from 4 to 8 week intervals. So that's a factor. Multiple comorbidities, particularly if they have up to severe degrees of retinopathy, there likely may be other things going on in their bodies for sure. But I also think, there can be issues related to scheduling, definitely on our kind of practice side, and other sort of more practical factors like that. But I think in our diabetic patients, more commonly we anchor around their busy lifestyles and multiple comorbidities. And that's why, the hope is we now have treatments that last a bit longer, and in the future we may have treatments that last even much longer than what we have now. And I think that really will help these patients that are not so well able to kind of manage all the multiple medical problems that they have. And on the retina side, we can relieve one of those issues a bit by saying, well, we're giving you a treatment that lasts so much longer. And in that interim, hopefully you're able to focus on all of the other things that may be going on in your life, particularly with your health.
Well, it's an interesting approach to understanding why increasing durability and decreased treatment burden is of tremendous practical importance.
Definitely. And I'm hopeful for treatments that are in the pipeline that may give us more time and also allow us to study study their long-term effects in the real world as well.
Do you want to speculate about Aflibercept 8 milligrams and Ferhina in the new world of diabetic macular edema?
For sure. So Ferhina is, commercially available since January of 2022. So we have over, getting it in our hands and all of that. We have over a year of information on that. And there's been real world studies like the Truckee study, the Ferhina AMD and DME studies, which use the IRIS database, which I've spent some time working on. And what we've seen already so far with faricimab is that providers have felt comfortable based on, I think, the clinical trial data to switch their patients, probably their more refractory patients, to faricimab and extending their dosing interval sort of very quickly. So in other words, we've seen that most of the patients that were initially receiving faricimab were not treatment naive. They had received prior treatments. Most oftenly, they had been switched from Aflibercept. And within 1 to 2 injections, providers were extending their intervals 6 weeks or greater. So that gives you a sense for the degree of confidence in the product based on the clinical trial results, the safety profile, which is of course very important, and the comfort with administering the drug in that respect. Now, in terms of high dose Eylea, we don't yet have that in our hands for sure, but the clinical trial data has been very promising in terms of durability. Most recently at the ASRS meeting, we saw impressive percentage of patients with treatment intervals of Q20 and even Q24 weeks. Now, of course, we see those numbers in clinical trials based on clinical trial design and allowance for retreatment criteria. But nonetheless, I think those are promising, very promising findings that as retina specialists, we're of course going to want to have the medication in our hands and see how it works in the real world. So I think that we're, with the rollout of these drugs, we're also, in a time period in which we have access to these databases. So the Ferhina AMD and DME studies, we looked at the first 9 months of patients getting this drug, which we weren't really able to do at such a large scale when we had our prior treatments. So we're going to learn a lot very quickly with the high dose Aflibercept too, I'll imagine.
Intensive treatment is important. Top line conclusion.
Yes, definitely. That is the top line conclusion.
And it will be very interesting to repeat this study in a few years.
Definitely, I would agree with that. And I think we'll have more tools to be able to do that with Vestrum database, IRIS registry, and that'll provide us with some important information.
Well, Ferhina, this was a wonderful conversation, very valuable for our audience. Thanks for joining us on Retina Synthesis.
Thank you so much for having me. Have a great day.